if you're diagnosed with this, or if you have this family history, a genetic testing or genetic referral is automatically a part of what we do. If you have a breast cancer, you see the medical oncologist, you see the surgical oncologist, and you see the geneticist.
Hello, everyone. I am really excited today. And I know I say that every episode, but I'm actually really excited because we have a very special guest today, Dr. Dallas Reed. And I'm just going to give you an opportunity to tell the audience a little bit about yourself and your journey to medicine.
Well, thank you for inviting me on your show. I'm also excited to be here. So my name is Dr. Dallas Reed. I am the Division Chief of Genetics at Tufts Medical Center in Boston. And I am the Director of Perinatal Genetics here. I'm a general OBGYN here as well, and an Associate Professor of Obstetrics, Gynecology, and Pediatrics at Tufts University School of Medicine. I practice clinically as a mostly obstetrician. I don't do a lot of gynecology anymore, and medical genetics, seeing patients of all ages from the prenatal setting all the way to older age. So a very interesting work and interesting mix of patients on a daily basis.
That's awesome. And I love to ask our guests because everyone enters medicine for different reasons. They may have had like a family member, or they may have done a different career and then transitioned over to medicine. What was your journey to medicine like?
Sure. So I think you're asking sort of how did I get interested in this particular area of medicine? Because it is an odd one. I would say, there aren't a lot of geneticists in the country. There are definitely not a lot of obstetrician geneticists. I think there are approximately 30 to 40 that are general OBGYNs and medical geneticists. I also was instrumental in putting together like the first group that is on record that we can find of Black geneticists, medical geneticists. And I joked with somebody that I think I could probably count on one hand how many there are. And I was wrong. You could count on two hands. There are exactly 10 medical geneticists that are Black. So it is not a normal field that most people think about going into, especially as a Black physician. But my story sort of started with a family situation. So when I was in first grade, my mom had a baby with a genetic condition. This was in the early 90s. We didn't know about it before she delivered. She had him prematurely, kind of like an emergency C-section. And after he was born, our family and the doctors didn't really know what was wrong with him. Eventually, they did figure it out, and he had a chromosomal abnormality, which was life-threatening. He survived for 4 months. 2 of those months, he lived in the NICU, and then the last 2 months, he came home and then passed away at home from like a cardiac event. We were told, we have no idea how long he'll live. He may not make it through the night. And so the fact that sort of a 4-month lifespan was one that we got to enjoy him was, more than I think we were expecting, and all very appreciative of that time. So I was in first grade when that happened. And I say that I always wanted to be a doctor, and I proved that to myself one time when I was moving from my fellowship in New York back here to Boston to work here at Tufts. And I was searching, my mom sent me like all the stuff you make from like preschool through whatever grade, all those crafts you make for your parents. I don't know why she sent them to me, but she moved houses. So she mailed it all to me. And I was trying to decide, I was going through the box and trying to decide, do I need to keep this and move it again with me to Boston? And I found something that I wrote when I was in 4 years old that said I wanted to be a doctor when I grow up. So I did truly always wanted to be a doctor, but not until I was in college. I went to Dillard University in New Orleans, a historically Black college. Not until I was there and applying for this scholarship to study abroad in the UK. It was called the Luard Scholarship, and it paid for me to study abroad in the UK, whatever school I wanted to go to for an entire year. And as a part of the application, I had to decide which school I wanted to go to and why. And I was like, what do I know about the UK? So I started to really try to think about, well, I know I want to be a doctor, but what kind of doctor do I want to be? And what do I want to focus on? And that's where I really started doing my research into genetics as a clinical field. I didn't think I wanted to do research, although there's lots of genetics research, obviously. But that's where I sort of saw that combination of obstetrics, gynecology, genetics, maternal fetal medicine is also in that space, so high risk obstetrics, and thought that that's what I wanted to do. So when I entered medical school, I was pretty intentional about like investigating that path and looking down that path. I mean, I never met anybody that did that job, even in medical school. I hadn't met an OBGYN geneticist, and not, I didn't meet anybody in that space until I was already a fellow.
Wow.
So it was just sort of that life experience and the idea that I wanted to be the person that my family needed at that time. Genetics can be hard in the sense that we don't have a lot of therapies for things, although that is changing with gene therapy. But it is actually very helpful for families to have information and a diagnosis and talk to other families that may have children or family members with the same genetic condition. That actually is very helpful. And so, lots of things have happened in my life after sort of making my decision to go this direction that have reconfirmed that I am in the place I'm supposed to be. But that was sort of my path to here. And I truly, feel like obviously my brother had something to do with it, but, recognizing that being able to put myself in the position of our family at the time is like something that I get to do every single day, which I think really helps like keep me connected to what I'm doing.
I think that that's an amazing story. And all of the students who are listening always hear me and our guests talk about like finding your why. And the start of your career started earlier and it was surrounded by a tragedy. But from there, you have been able to impact so many. And like you said, you're one of 10 Black geneticists like in the country. That's crazy.
Yeah.
You did mention that you had not even really interacted with a geneticist while you were in med school. For those listeners out there, Dr. Reed and I both went to medical school together. And I don't think that I had maybe one. I don't even remember. But it just showcases that when you have an interest, even though there may not be many people in the field that have come before you, or you may not have been able to shadow or experience and those types of things, seek it out and learn more about it and try to kind of figure out your why and how to get to that path. As you mentioned, there are not a lot of obstetricians who are geneticists. What other pathways can people go in order to pursue genetics if they don't choose to go into OBGYN?
Sure. So genetics is, as you can imagine, incredibly diverse as far as the types of things you can do for your career. So there are obviously research pathways, getting PhDs, et cetera, going that direction. And, doing research on human genetics, viral genetics, animals, there's just like everything that has DNA. You can focus on genetics in that space. From a sort of patient-facing way, there's really two things. One is focusing on the laboratory. So the laboratory that does the genetic testing, people that go that route are typically PhDs or maybe MD PhDs, but definitely have a PhD, and they are training to be lab directors. So there's sort of three types of genetic laboratories. One is called biochemical genetic laboratory, which is where we do, but they do analysis of things like amino acids and organic acids and help to diagnose a group of conditions that are called metabolic disorders or inborn errors of metabolism. So that's one route. There's also cytogenetics, which looks at our chromosomes, our karyotype and our chromosomes, and looking for things like Down syndrome and other chromosomal disorders, the ones like that my brother had. And then the third type is called molecular genetics, and that is looking at sort of the DNA sequencing technologies that we use nowadays, like pretty much in every patient we see in genetics that gets testing. So that is a really interesting area, like developing tests or using that type of testing to advance medical knowledge. From like a clinical genetics perspective, there are a few training pathways. So one is sort of patient-facing. It's called molecular pathology. So those are people that will go into pathology and then study some about molecular genetics, and they tend to focus their work on analyzing DNA changes in tumors or tissue. So it's not necessarily mutations that people are born with, but things that help make cancer happen, for example. So they sort of focus on that. And the reason that that's important is because we know that there are treatments targeted towards cancers specifically that have particular mutations or particular genes affected. So that's why that area of medicine exists. If you want to see patients in the clinic, the way to go about that is there's several combined programs, genetics combined with another specialty, or you can do them sort of separately like I did. So there's a pediatric and medical genetics combined residency program. Pediatrics, as you may know, is a 3-year program. Genetics fellowship is a 2-year program. So if you do a combined fellowship, they cut it back by a year and it's a 4-year program. There's also internal medicine and genetics combined programs, and those are 4-year programs. And then there is 2 that are fellowship combinations. So one is maternal fetal medicine and genetics. So you have to do your OBGYN residency first and then do an MFM genetics fellowship. And then there are a couple REI genetics fellowships, so reproductive endocrinology and infertility. So again, you would do an OBGYN residency and then do the fellowship. But for people that don't want to do a combined program, which there's many reasons why you may not want to, you could do them separately. You could do pediatrics and then apply again and do a fellowship in genetics. And that's what I did. I did OBGYN and then applied into genetics as a fellowship. So there's lots of different pathways to get there. And I don't know if you have websites that you want me to share with you for people that are interested. I can certainly share that with you to post for people to look up kind of the pathways.
Absolutely. That sounds like there is such a diversity in the experience in the genetics realm. And it's certainly a need, everything ranging from, you said, like REI, where people are trying to become pregnant and bring life into the world, or cancer research. So there are so many different things that you can do as a geneticist. So we will be placing those resources where you can do more investigation in our show notes. For you, I have a question for the students who may be interested after you just talked about all of the different ways that they can go into the field. What would you say is the biggest piece of advice for someone that is interested in going into genetics in terms of how they can pursue it, especially being as though a lot of medical schools may not have it offered as an elective?
Yeah. So there's a couple things. One of the links that I can send you has a program sponsored by the American College of Medical Genetics, which is like our big college, that has like summer internship programs for, I think, college students as well as early medical school students. There's a research pathway to get exposure that way. Another thing you could do is talk to, usually genetics is a course you take in medical school. And it may not be a clinical geneticist that's doing that course, but you could talk to the people running that course to see if they know any clinical geneticists that you could talk with or shadow in order to get exposure, because it's like unlike anything you'll ever experience in medicine. Like it's just a whole different type of patient, a whole different approach to the care, a whole different just conversation that we have with patients. It's like very focused on the family and figuring out something for an individual, as well as sort of what the implications are for their family members or future children, all of that. Also, you could reach out to me. I'd be happy to sort of connect you with somebody that's in your area. I have like social media networks of geneticists that I keep in touch with, because it is a small group. We are very collaborative, and we want to help each other out, and we want to recruit people into this field because we think it's like so awesome and so necessary, but definitely not as popular as like other specialties.
That's awesome. You are also quite an advocate for health equity. How can we work to create more equitable spaces in the genetics realm?
Yeah, so there's a couple things that I think about when I think about equity in genetics. I mean, there's probably a million things you could think about, but one is something, it's sort of technical, but very, very important to how we use genetic testing to help take care of patients. So what happens when somebody gets a genetic test, a sequencing type test, is, which most genetic testing is nowadays, is that we get DNA from a patient and we compare their sequence of DNA to something that's called the reference genome. And so what happens in the laboratories, they're comparing at every nucleotide, they're comparing to say, is this the nucleotide we expect, or is there a different one there? And after they've determined that, they have to decide if the ones that are different are problematic or not. Sometimes we know that there are common differences that we see all the time and they mean nothing at all. And so those are considered benign changes that are like perfectly acceptable and would never actually be reported out on a genetic testing report for me to review. There are ones that we know are clearly problematic. They clearly change the function of the gene or the protein. We know they're associated with disease, and so those are pretty clear cut. But there are some in the middle that we call uncertain findings that we're not sure about. Maybe there's nothing in the literature about that particular change. Maybe the lab that's doing your testing has never seen it before. There's just not enough association between genetic problems and that particular or that condition and that genetic change. The reason that this matters is because if the reference genome, which it has been up until recently, is primarily Caucasian European individuals, there may be variation in places for someone that doesn't fit that ethnic ancestral background that leaves us with a result of uncertain because we haven't done enough, we haven't looked at enough variety for the reference genome to know like if this variation is one that's just normal in certain populations or not. So that is something the field is kind of trying to tackle now. Is there's something called the All of Us research program, and they're trying to get DNA from 1 million people and vary the type of backgrounds that we're getting the DNA from. And one of the reasons is to help diversify that reference genome so that we're not left with a patient that's Taiwanese and Jamaican background, like left with all of these uncertain findings on their genetic testing result, where if they were like a Western European Irish person, like we would definitely not have that type of result. Mm-hmm. So that's one area. Another area that I practice a lot in clinically is in cancer genetics. And so cancer genetics is when we see patients who have a personal or family history of cancer that is considered high risk, meaning there are some red flags that make us think this is not just the normal cancer that just happens by chance. This is a cancer due to a genetic mutation that somebody has and has been passed on to their family. So we know that there's differences in sort of the referral rate for somebody who is of a non-white background being referred to genetics or having genetic testing. We also know that there's a difference sometimes in outcomes based on those genetic testing results and sort of cancer risks and severity of cancers and aggressiveness of cancers. So that's another area of focus, is to sort of make it so that there's just standards. Like if you're diagnosed with this, or if you have this family history, a genetic testing or genetic referral is automatically a part of what we do. If you have a breast cancer, you see the medical oncologist, you see the surgical oncologist, and you see the geneticist, because all of those things could be important in taking care of you for your cancer. But the thing about hereditary causes of cancer is that we know that they can cause other cancers in your body. So we deal with this breast cancer, but you may be at risk of ovarian cancer or pancreatic cancer or other cancers, and your family members may be at risk as well. So it's really important that we don't just give that type of service to certain individuals and ignore other individuals who may benefit from that information.
That makes complete sense. And just seeing all of the different things and all of the different databases that are out there. For instance, I went to a health equity conference this week, and there was a lot of discussion in terms of how to study different populations in order to bring different things like cancer research. They were specifically talking about colon cancer in Chicago, but other ways and how you can implement that, or how you can work with other organizations that have collected all of this data but aren't partnering with medical entities to actually figure out how to utilize it. So I think that that's something that is very necessary in our field, to figure out not only how we do the medicine and how we do the studies and all of that, but how we can partner and get out there in the community to even bring people into the clinical trials and the studies and things, so that we can have more data to utilize and help people.
Yeah, like that trust between the community and the researchers is definitely, I mean, there's good reason, right, that people don't trust medical research, but we do need to sort of outreach and try to help certain communities understand why their perspective is helpful.
Absolutely. We are coming to the close, but one of my final questions for you that I love asking all of my guests is, to be completely honest, the healthcare system is broken. It's not perfect. So, if you had a magic wand, what is one thing that you would change about the healthcare system?
I mean, I think there's just, maybe this is a popular answer, but there's so many middlemen between the physician and the patient getting what they need, right? I mean, this happens in genetics a lot because genetic testing is expensive and constantly changing and improving, and genetic insurance companies aren't necessarily like keeping up with it. They don't necessarily want to pay for all of it. So we always have to go through a process of prior authorization and getting, permission to do the thing that we think is medically necessary for the patient. So, a single payer system would possibly be helpful in eliminating some of these middle people that just really add like a waste of time. Like, I don't have the time to fill out some electronic form explaining why I'm using my medical expertise to recommend a particular test for a patient who I think may have a particular diagnosis, and then have that form be rejected because it doesn't meet their criteria, which are not based on anybody's medical expertise. And then I have to talk to somebody to do a peer-to-peer to see if I can convince them that me using my medical expertise to help this patient is appropriate. And when I'm talking to that person, it's a peer, meaning it's another physician. Maybe it's actually a nurse practitioner, but they actually don't know anything about genetics. They're not a geneticist. They're a urologist. They're something else. Dermatologist. I don't know. They're not a geneticist. And so I'm saying things that they don't even understand. So that is completely crazy.
Mm-hmm.
Like, I know what I'm doing. I know what I'm worried about. I know where I could get the testing done. I've thought about the cost. I've thought about all these things. Mm-hmm. Can I just do it so that we can make a diagnosis for our patient? I think the other place in genetics where it gets really frustrating and where it feels like there's a lot of middlemen is when you're thinking about, again, genetics isn't just about the individual, there's familial implications. So if I have a patient that's what we call a carrier for a genetic condition, and I want their partner tested to see if their partner's a carrier so that they know if them together are going to have children with that particular condition, the partner's testing may not be covered by insurance. They may have to pay out of pocket for that. And the reason for that is that maybe they're on different insurances. And so one insurance doesn't care about the other insurance. And if the baby's only going to be on one of their insurances, then both of them don't need to pay for the medical expense or complications that could come from this very rare, serious genetic condition. It's like just completely crazy that that they're just sort of saying, not it, not me. And, the patients are what's stuck in the middle with bills or not getting things done because they can't afford it. So I would get rid of all the middle people. Which should bring costs down tremendously and stop wasting everyone's time with checking boxes for them to prove that I know what I'm talking about when I'm board certified in the two specialties that I'm certified in, and therefore it's been determined that I am competent in this field and know what I'm doing.
I couldn't agree more. For the students who haven't made it there yet, you will learn. It is a system that needs to be changed, and I think that the onus is on you guys to change it. I think we're at a pivotal point in healthcare where they're integrating technology, they're moving forward, they're trying to think of other things. We are going into an election year, and I know that all of the systems and things try to say that healthcare isn't political, but it is. It's more about the political determinants of health than the social determinants of health, because the political determinants do determine what is going to happen with all the other realms of healthcare, and everything comes together. So I think that is important.
And that's true because our organizations have lobbyists, right? Yes. Like AMA has lobbyists.
Yes.
Like they have to go make the case to these these politicians that, as we can see with a lot of the discussions around like reproductive health and reproductive justice, like they don't even understand biology. Like,
it's so true.
You know, if you miscarry at 6 weeks, you could be criminally liable. It's like,
it's crazy.
Like you don't even know you're pregnant at 6 weeks most of the time. Like it's just kind of like no understanding of biology, but yet they get to make the decisions about our health. It's very disorienting.
Absolutely. And just reflecting back to the conference that I mentioned earlier, they interviewed the physician who led the sequencing of the human genome, which was like historic. And with them telling the story of how it happened, it was about 40 scientists or something at some kind of retreat when they were trying to figure out how to get it financed and all of these things. And it took the one figurehead who was a billionaire because they couldn't get in the same room with the senator. You can't email a senator directly, even if you are the Secretary of Human and Health Services, which is crazy. But they had to get the billionaire to set up the call so the senator could call them. And within a week of the billionaire meeting with them, it was on the Senate floor to be voted for. So you can't move forward in advanced science that has helped so many, even in your field, until you get the politicians to call you. So there are so many things that you as the students need to look into, because hopefully you're going in this to help patients. So we have to figure out better ways and better mechanisms in order to help advance our healthcare system, especially since we're the only highly industrialized nation without some form of universal healthcare. They all work differently. There are pros and cons to each one. I'm not saying we have to adopt a specific one or get rid of private insurance, but we have to come up with a way collaboratively to work together.
Yeah, for sure.
So it was so wonderful to have you on the show and share all of your words of wisdom. I'm going to give you an opportunity to tell the audience goodbye. And I know that you're going to let us know something we can put in the show notes for the things that you mentioned and how to reach out to you.
Yeah, definitely. Please don't hesitate if you have questions about OBGYN, which is probably relatively easy to find an OBGYN, but genetics, OBGYN and genetics together. If you have any questions about sort of that pathway, happy to talk about that. And I really appreciate the opportunity and hope to see some of you one day as a colleague in my field.
Thank you so much for joining us. For all of the listeners out there, you know, you can find us wherever podcasts are found. And you also can find us on YouTube. If you have any questions, you can reach out to my Instagram, Dr. DOCTOR, the letter D, Graham, GRAM, Dr. D Graham. And you can let me know if there are any topics you want us to discuss or any guests that you want us to invite. And we'll see you again next week. Have a good day. Bye.
Each episode of the Prospective Doctor podcast is brought to you by Med School Coach. To access articles, videos, webinars, and free tools to help you succeed on your journey toward med school and beyond, visit our website, prospectivedoctor.com. We hope you tune in again next time.